Thank you for your patient hearing. Fag end of the day. I know everyone is tired. So we'll just show the videos and move quickly. The eyes don't see what the brain doesn't know, borrowing from our surgical textbook. So we have a case, 20-year-old lady and 31-year-old gentleman with primary infertility of 2 years, irregular cycles. OI was given, and let us look at her ultrasound findings. So this is the uterus. You can see the ovaries, you can see the follicles, antral follicle count. As already elucidated earlier, follicular number per ovary, if we look at, if it is more than 20, we give the diagnosis of PCO, or rather on ultrasound, it is a diagnosis of polycystic ovarian morphology. So PCOM on scan. So she has irregular cycles, PCOM, a diagnosis of PCOS, so OI cycle was given. So how do we check the antral follicle? We know antral follicle, when we look at the recruitment, there is two phases, initial and cyclic recruitment. So cyclic recruitment is the one wherein we manipulate the follicles. Initial recruitment is something which happens on a regular basis in women, but cyclic is the one which we manipulate during our ovulation induction or ovarian stimulation. So antral follicles, we measure them on day 2 to day 4. So we can measure them normally on a 2D ultrasound, or we have an automated sono AVC also to measure the follicles. This video we are measuring the uterus, the APD and the uterocervical length, and also looking at the follicles. If you can see, when we are moving the probe from side to side, you can see both the ovaries. There is an average number of follicles, more than 10 follicles combined AFC. So we can take it as a normal reserve. Then moving on to the next scan, if you look at this patient with the ovaries, hardly there are some 2 to 3 follicles in each ovary. So this indicates diminished ovarian reserve. So when do we call diminished ovarian reserve? If the AFC is less than 5 to 7 in both combined.
So moving on to the next case, 24-year-old Mrs. A, 28-year-old Mr. B, anxious to conceive since 2 years. They started on ovulation induction for an IUI cycle in view of unexplained infertility. So this is a scan finding. So this is a case of secondary infertility. We can see that there is a scar there, cesarean scar is visible. There's no point. So this area you can see there's a discontinuity. So this is how we do a complete assessment. Transverse we are seeing. Now we do a 3D. You can see the discontinuity clearly even on the 3D. So this area. You can see that defect, that's the cesarean scar area. So let's look at the ovaries because we've given ovulation induction. So this ovary doesn't have any dominant follicle. So as we scroll to see the next ovary, we're taking the measurement of this ovary. So there is a dominant follicle over here. It's more or less rounded, so the measurement is quite easy actually. But many a time the follicle is actually not rounded, and there's always a dilemma as to how to measure. So inner to inner in the largest diameter and axis perpendicular, 2 diameters, and if you take an average, that should be a follicular measurement. So when it is rounded, ideally one single diameter is okay, but when it is like this, ideally this is how it has to be measured. The largest, the follicle has to be exposed in the largest diameter, measure the largest diameter and take the measurement in the opposite direction and take an average of it. So follicular study ideally should be started from day 2 itself. Day 2 scan is very important because you should rule out any cyst of the previous cycle. If you directly give oral ovulogens and ask the patient to come back for a follicular scan, we might mistake the cyst as a follicle, as a dominant follicle. So role of color Doppler enhances our follicular scan monitoring, and by looking at the vascularity, we can enhance the success rates by giving the trigger at the right time. We are looking at the perifollicular flow and measuring the peak systolic velocity and RI. So the follicle measures almost around 16 millimeters. It has quite a good vascularity. when we are doing Doppler, we should make sure that the PRF is around 0.5 to 0.4. So generally the machine is set at around PRF of 0.8, 0.9, and that detects only the larger vessels. The perifollicular and the subendometrial flow are the smaller vessels, so the PRF has to be set to 0.4 to 0.5. Only then you will see the perifollicular flow or the subendometrial flow. So in this particular patient, the peak systolic velocity is 8 to 9 and the RI is 0.9. So this shows that there is still some more time for us to give a trigger. So a mature follicle is one where the follicle is around 3/4 by vascularity, and when you see the perifollicular blood flow, if the PSV is 10 to 15 and the RI is less than 0.4, it is ideally the right time for us to trigger. So now this is one more follicle. So almost 3/4 it is surrounded by vascularity. Now if you look at the PSV, it's almost 10.5 and the RI is less than 0.4. So this is a follicle which is ready for trigger. So perifollicular flow, as the blood flow surrounding the follicle increases, the chances of having a mature oocyte increases. So the one which has maximum blood flow, the resistance index will be low, and it is a good follicle for us to trigger. So blood flow is also important to check the subendometrial blood flow. So this is a good zone 3, zone 4 vascularity. Again, we have to be mindful that the PRF is set to 0.4, 0.5. If you keep the PRF at 0.8, 0.9 and you won't see a single vessel and you will misinterpret, so you have to be a little cautious about that. So this is the Applebaum classification of subendometrial blood flow. The vessels are hardly seen in the myometrium, they are not even touching the endomyometrial junction. In the second scan, you see they are almost approaching the endomyometrial junction. Zone 3, it is up to the endomyometrial junction, and zone 4, it is up to the cavity. So this is how we stage, and zone 3, zone 4 is ideal for us for an implantation. So another importance of doing Doppler in a follicular scan is if the PSV is already high, say it is around 15, 20 or 30, then we have to do an IUI earlier. That means there is already an imminent rupture. You can't give a trigger then and wait till 36 hours because the follicle would rupture earlier. So that is another importance where you can time the IUI better and you can improve the outcomes. So ideally trigger should be given when the follicle is surrounded 3/4 by vascularity. It has PSV more than 10 and RI less than 0.4. So after giving a trigger, it's ideally not mandatory to do a scan. So the evidence right now says that 36 hours later, documenting ovulation is not mandatory to do an IUI. So if at all we do a scan, then there are varied appearance of corpus luteum that we come across. So this is one video showing the scan post trigger. So we have a good secretory endometrium in this patient. We can already see the first sign of rupture. We see free fluid there. So this ovary is looking normal. The opposite ovary, you can see the corpus luteum. So it's something like a hemorrhagic cyst. It's a corpus luteum with very good vascularity. So it's a good sign for us.
Moving on to the next case, we have a 35-year-old lady and 30-year-old gentleman with primary infertility of 2 years. So she has regular cycles but spasmodic dysmenorrhea, heavy menstrual bleeding lasting 8 days. So let us look at her ultrasound findings. So here in this ultrasound you can see a fibroid, okay. The measurements are being taken about the fibroid. So fibroids usually present like a hypoechoic masses. Very rarely they present hyperechoic. Most often it is iso to hypoechoic mass in a sagittal plane. So for fibroids we do what is called fibroid mapping. So you do ultrasound, take the measurements of the fibroid in the sagittal plane and also in the transverse plane, and you take the measurement of the fibroid from when you move the probe from cervix to fundus. That is, you ideally locate the fibroid. And also we do the 3D scan of the fibroid will give us the location of the fibroid and its distance from the junctional zone. So for fibroids, we know we are clear cut about the management that subserosal fibroids do not affect fertility, whereas submucosal fibroids need to be removed. But the gray zone occurs in intramyometrial fibroids, wherein these fibroids are located your FIGO 3 to Figo 5. So if the fibroid is somewhere close to the junctional zone, then we need to remove the fibroid. Otherwise, there is no role of removing the fibroid. So for submucosal fibroids, we have the Lasmar classification. So recommendation is if the fibroid is larger than 4 centimeters, reaching the junctional zone, then it needs to be removed.
So moving on to the next case, 26-year-old lady, 30-year-old gentleman presented to the hospital with secondary infertility of 5 years. She had 5 previous spontaneous miscarriages at 8 to 10 weeks of gestation. So this is her scan. So this is a sagittal section where it looks quite a normal uterus. But when you see the transverse section, you can see that the cavity is dividing. So once the cavity is dividing, you know that we are looking at some uterine anomaly, query septum, query bicornuate, query didelphys. So in a 2D scan itself, we can more or less differentiate between a septum and a bicornuate, because there is division of the myometrium as well when it comes to a bicornuate uterus. So now when we do a 3D scan, we see that it's a septate uterus. See, there is the external contour is maintained, right? And you can see the cavity being divided into 2. Yeah, so you can see the 2 cavities, and the external contour is still maintained. So that is why you can differentiate it from a bicornuate uterus. So this is the Ishre classification of uterine anomalies, and this is the next case. So in this you can see that the cavity is extending up to the left ostium, but towards the right ostium you don't see the cavity. So when we put a 3D, we see it's a unicornuate uterus, and there is even a small polyp inside. So this is a unicornuate uterus with a small uterine polyp. So based on the surface indentation, we can differentiate between various anomalies. So you look at this, the surface is intact. This is a complete septum. If there is indentation of the surface as well, as I have marked over here, it is a bicornuate uterus. And based on the depth of indentation of the inside, you can differentiate between arcuate and septum. So if the indentation is only 1 to 1.5 centimeters, it becomes an arcuate uterus. Now this is the septum, and this is a septum extending even up to the cervix. This is a video of a hypoplastic uterus. So it's a less than normal size uterus, and ideally it should be differentiated between an infantile uterus, where in an infantile uterus the cervical length and the fundal length will more or less the same. So if it is a hypoplastic uterus, there is a scope to give hormone replacement therapy and go for a donor cycle. But if it's an infantile uterus, the response may not be very good.
So moving on to the next case, again we have a couple suffering with primary infertility of 5 years duration. She has intermenstrual spotting, but otherwise regular cycles and occasional spasmodic dysmenorrhea. So let us look at the scan findings. So here you can see a clear polyp on your sagittal plane. So the polyp can be measured. So how do we differentiate between a polyp and a submucosal fibroid? So one polyp, you can see it causes splitting of the endometrial cavity. You have a central line that is split. Whereas in a submucosal fibroid, the origin is from the myometrium. So you have pushing out of the endometrial line. So in 3D also you can see the origin of polyp. It is arising from the fundus and extending downwards. So ideal way to differentiate between polyp and submucosal fibroid is to put a fluid as well. So you can do an saline infusion sonography wherein you can see clearly the polyp moving. And also if you put a color Doppler, for a polyp you will identify a feeding blood vessel, whereas in case of submucosal fibroid you have a peripheral uptake. So polyp, one, you need to look at the location, and SIS has better sensitivity and specificity for identifying the polyp from a submucosal fibroid. So for management, less than 10 mm polyp, and if it is lower in cavity, no need for management. Conservative is advised. But for more than 1 centimeter polyp, probably removal helps.
So the next case, Mrs. X and Y, anxious to conceive, trying for pregnancy since 3 years, tried few cycles of ovulation induction and timed intercourse. Male partner evaluation was normal, so now we've called her for a tubal patency test. So this is a video of saline infusion sonography. So we have inserted a pediatric Foley's into the uterine cavity, distended it with up to 2 ml of saline, and now we are looking for the flow. So clearly you can see at one ovary you can see the flow. Now we are looking on the other side. Again you can see the flow. Can you observe? initially it may be a little difficult to do a saline infusion sonography, because by the time by the time you're able to put your probe and look at the ovaries, sometimes the fluid has already come out, then you won't know from which places it's come. So with skill, if the sooner you do it, you will be able to appreciate. So this is another video. You can clearly see the fluid coming and dropping near the ovary. This is more clear, I guess. And this is the opposite ovary. Here again you can see the fluid coming and dropping near the ovary. So most of the tubal patencies we are doing at our own hospital with saline infusion sonography. Only in certain conditions we are sending for a HSG, because several times HSG is quite painful, and getting it done at a radiologist is not a very comfortable thing for a lady. So this is definitely a better option for them. And you can also evaluate the uterine cavity problems. So as the cavity distends, if you have any small polyps or anything, it can be easily visualized.
So moving on to our next case, we have a 33-year-old lady and 38-year-old man with 5 years of primary infertility and regular cycles. So let us look at the scan. So this is the sagittal plane. Here again we are measuring the UCL, uterocervical length, and APD. You can see clearly there is a endometrioma. It's a spotter, so ovarian endometrioma. So this endometrioma, already we have discussed in the earlier presentation. So endometrioma, ovarian endometrioma, typical sign is ground glass appearance. So you can see when the other ovary is focused, there is a uniform homogeneous ground glass appearance of the ovary, the cyst. So this is a two endometriotic cysts are present in the left ovary, and this ovary is adherent. You can see it is adherent to the posterior surface of the uterus. So in endometriosis, as elucidated earlier, we need to look for adhesions. See, we have identified a ovarian endometrioma. Is it adherent? What is the ovarian reserve in this patient? And what are the atypical signs? Sometimes you might not see such clear endometrioma. You have doubts whether is it a hemorrhagic cyst or is it an endometriotic cyst. What you need to understand is, in case of hemorrhagic cyst, it resolves. So you can call the patient back again on day 2 to check if it is persisting. And another atypical sign of endometriosis is sometimes you do see fluid levels. So what happens is it's endometriotic cyst is a chocolate cyst. So you have a hemorrhage inside. So once the hemosiderin separates, you have fluid levels. So as William Osler once said, he who knows endometriosis knows gynecology. So we will not go into idea consensus. Already this was elucidated earlier.
So 36-year-old lady presented with primary infertility of 8 years duration. She had regular cycles but associated with dysmenorrhea. Male partner evaluation is normal. This is her scan. So this is a patient with adenomiosis. So you can see cystic spaces in the myometrium. The anterior wall is disproportionately larger than the posterior wall. You can see the alternate banding pattern. So you have so many features in favor of adenomyosis in this patient. Yeah, there are myometrial cysts as well. And there is uptake of vascularity, which again supports a diagnosis of adenomyosis. So adenomyosis, now we have the MUSA guidelines, where the direct features are cysts, hyperechogenic islands, echogenic subendometrial lines and buds, and the indirect features are asymmetrical thickening, fan-shaped shadowing, translesional vascularity, globular uterus, irregular junctional zone, and interrupted junctional zone.
So moving on to the next case. So we have a couple who had one IVF done outside 2 years back and failed to conceive. Her previous reports have shown persistent fluid in the endometrial cavity. So this is the scan findings. So we have again the sagittal plane of the uterus. You can see this is away from the cavity. It is at the cervical level. In the transverse plane, you do not see the fibroid at the fundus. But when we come to the ovary, you can see a large fluid-filled cystic structure. So this is something similar to Hydrosalpinx. So what is the differential diagnosis? Either you have a paraovarian cyst or a Hydrosalpinx. So how do you differentiate? Paraovarian cyst, if you see any fluid-filled cystic structure, rotate your probe in a transverse direction. So if the shape is maintained, either it becomes round, oval, but the shape is maintained, then it's ideally a paraovarian cyst. But if it's a Hydrosalpinx, it becomes a septate, partial septate, lobulated structure. So this is typical of Hydrosalpinx. And another thing is the fluid which is coming into the endometrial cavity. This also shows that it is a Hydrosalpinx. Here in the other ovary, we have a nice corpus luteal cyst. So For Hydrosalpinx, we know that this fluid is detrimental for implantation. So the management ideally is to remove, that is salpingectomy, bilateral or unilateral, depending on which side the hydrosalpinx is. If not, at least tubal clipping. So Cochrane supports both. There is not much role of antibiotics. The role is controversial, and there is no role of aspirating the hydrosalpinx because it refills again. And hydrosalpinx repair is not possible because it's like a stretched elastic band.
Mrs. A married since 10 years, para 2 life 2, secondary infertility. She was anxious to conceive again, so she underwent recanalization, and 1 year post surgery she came with amenorrhea, pain lower abdomen, UPT was positive. Now this is her scan. So we can see a thickened endometrium, but we don't see any sac inside the endometrium. As we scroll and we look at the adnexa, we can spot ectopic pregnancy. So that is a gestational sac seen in the right adnexa. It has a perfect ring of fire appearance when we put the Doppler. So it's currently an unruptured right tubal ectopic pregnancy. So any antenatal scan is incomplete, especially in a patient who has conceived with ART if you don't look at the adnexa. So this is one patient where we have seen an intrauterine sac, but definitely we have to scroll and look at the adnexa because there is always a chance of a heterotopic pregnancy. So when the mean sac diameter is 20 millimeters, we should see the fetal pole, and when the fetal pole is 7 millimeters, we should see the cardiac activity. So these are just simple take-home points, and this is a good corpus luteum in that antenatal scan as well, which is supporting the pregnancy. So thank you all for your patient listening. I know it was a very long day. I'm sorry we rushed it because we didn't want you to stay here for any more time because you already had a lot of patients. So thank you so much.